Hello and welcome. I'm Heather Mannion, and I'm the Medical Science Liaison with One Lambda, and thank you for joining our webinar today. I'm really excited to introduce our featured guest speakers, Dr. Defne Magnetta and Dr. Nicoleta Arva from Ann and Robert H. Lurie Children's Hospital of Chicago. Dr. Magnetta is a pediatric cardiologist and assistant professor of pediatrics at the Northwestern University Feinberg School of Medicine, and she also is the fellowship director for the Pediatric Heart Failure and Transplantation Program. Her clinical research interests focus on improving assessment of acute rejection, both by invasive and non-invasive means to improve long-term graft survival. Dr. Arva is a pediatric pathologist and associate professor of pathology at the Northwestern University Feinberg School of Medicine. She's the Pediatric Pathology Fellowship Program Director and the co-director of the Institutional Biobank at the Ann and Robert H. Lurie Children's Hospital of Chicago. Her clinical and research interests include transplant, pediatric cardiovascular, pediatric gastrointestinal, and thyroid pathology. On today's program, Dr. Magnetta and Dr. Arva will discuss the ISHLT grading system for acute rejection and heart transplant, how MMDx Heart can provide additional information to guide clinical decision-making, and how MMDx Heart and pathology can be used together. This presentation will be recorded for future viewing through the One Lambda website. And during the presentation, please feel free to type questions to both Dr. Magnetta and Dr. Arva in the Q&A field. Questions will be answered at the end of the presentation. And if you need technical support, please put your questions into the chat and a member of our support team will assist you. So it's now my pleasure to turn today's program over to our presenters, Dr. Magnetta and Dr. Arva.
I just want to say thank you for inviting us to speak about our experience using MMDx in pediatric heart transplantation here at Lurie. I'm here with Dr. Arva, our pathologist, to discuss a few cases and some of our experience. So just to go over the learning objectives of today, we want to review the ISHLT grading system for acute rejection in pediatric heart transplantation. And as part of that, discuss some of the strengths and pitfalls of histopathology assessment. And then we want to go over some of the additional information that you may gain from using MMDx technology in specific cases of severe cellular rejection and in cases of antibody rejection where treatment may be unclear. So first, a little bit of background. As you know, heart transplantation is an important tool for treatment of advanced heart failure in congenital heart disease and cardiomyopathy. And it has a good prognosis with median survival of about 13 years in teenagers and above 20 years in infants. However, rejection still remains a common complication of heart transplantation and sometimes can have devastating complications. It occurs in about 22% of patients in the first year post-transplant and is frequently identified in surveillance biopsies. Endomyocardial biopsy is still considered the gold standard for rejection surveillance, but we do still experience scenarios of biopsy negative rejection, and those can be associated with poor outcomes. So I'm now going to hand over to Dr. Arva to just discuss a little bit more about the grading system for rejection using histopathology.
Thank you. We as pathologists have the role to grade rejection using endomyocardial biopsy tissue. We evaluate for two types of rejection: acute cellular or T-cell mediated rejection and antibody-mediated rejection. These two types of rejection are graded according to ISHLT grading system, which was initially developed in 1990, but then revised in 2004. Based on this system, acute cellular rejection is graded as mild or grade 1R, moderate or grade 2R, or severe grade 3R. And this is based on the amount of inflammation that we see in the myocardium, if it's focal or diffuse. It is also based if the inflammation is associated with myocyte damage and how many foci of myocyte damage are present. Antibody-mediated rejection is evaluated histologically and immunologically. Histologic evidence of AMR consists of presence of prominent vascular channels with plump endothelial cells. Usually the lumen of these vessels is dilated and it is filled with mononuclear cells such as macrophages and lymphocytes. Immunologic evidence of AMR is evaluated using staining, either immunofluorescence or immunohistochemistry for C4D, C3D, which are parts of the complement system, and or CD68, which is a marker of macrophage. AMR is graded as grade 1 if there is only histologic or immunologic evidence on the biopsy. It is graded as grade 2 if both are present, and it is graded as grade 3 when more extensive changes are noticed, such as hemorrhage, severe edema, and endothelial cell pycnosis and or choriorrhexis. This slide is showing some examples of cellular rejection and antibody-mediated rejection. On the left panel, we have, on the top left, we have an example of a case that had one single focus of myocyte inflammatory infiltrate, which was not associated with myocyte damage, and this was consistent with acute cellular rejection, mild grade 1R. The next panel shows two foci of myocardial inflammation, which are well confined. Both of them were associated with myocyte damage, and this was consistent with acute cellular rejection, moderate grade 2R. On the bottom left panel, we see a more extensive inflammatory infiltrate, which is diffuse, and it is associated with marked myocyte dropout. And this is consistent with severe cellular rejection, grade 3R. On the right hand of the slide, we have examples of AMR. On the top, we have histologic findings that are consistent with AMR. We see plump endothelial cells, and the small box here is showing a dilated lumen, which is filled with mononuclear cells. On the bottom, we have examples of positivity for C4D. On the left, we have an example of immunofluorescence, and on the right, we have an example of immunohistochemistry of a case that is positive for C4D. For a case to be called positive for C4D, we need to see 50% of the vessels highlighted by the antibody. For CD68, we need only 10% of the vessels to contain mononuclear cells. Endomyocardial biopsy has multiple limitations. First of all, it is an invasive procedure. The patient needs to be put under anesthesia. It has variable sensitivity, and this is due to sampling error. There is not a standardized way of reporting AMR. Not all institutions are using the same panel of antibodies. For example, some places will do only C4D. Some institutions will perform all three antibodies, C4D, C3D, and CD68. The biopsy, it is also subjected to a high rate of inter-observer variability. And this is due mainly to the fact that there is high variability in what pathologists call myocyte damage. In 2003, Lindop and al. Demonstrated good agreement amongst pathologists when the biopsy was negative for rejection or had severe rejection grade 3. However, there was poor agreement on those biopsies that had only mild rejection grade 1 or very severe rejection grade 4. In a similar study, in the current graft trial, Magnetta et al. Confirmed the findings. He showed moderate agreement for ACR, but only fair agreement for AMR when the institutional reads were compared to the central pathology group read. As such, molecular tests have emerged recently, such as donor-derived cell-free DNA and tissue-based gene expression profile or molecular microscope diagnosis.
So just talking a little bit about the MMDx technology, tissue samples are obtained with the biotome and sent for microarray analysis to assess for mRNA expression of various rejection and injury-related transcripts. These transcripts are grouped into pathogenesis-based transcript sets, or PBTs, to characterize a disease process, including rejection or injury, as well as normal myocardial tissue. And then this patient sample is then compared to a cluster map of a reference set of samples to determine which process is most likely to be occurring in that sample. And then what you get in return is a report that looks like this, and it gives you the scores for each of these PBTs, as well as a probability for diagnosis between no rejection, rejection, and injury. You'll see where your patient's sample, which is noted by the yellow triangle, where it falls within this archetypal analysis between rejection, no rejection, and injury. And then you will get a summary statement at the top that puts all of these pieces of data together to tell you what is likely going on in that sample. And the goal of all of this is to end up with a measurement of the respective biological process in the tissue and a probability of there being rejection or injury. So then we'll jump right into the different cases. This is our first case. It was a 15-year-old boy who had complex congenital heart disease consisting of heterotaxy, double outlet right ventricle, pulmonary atresia, a right dominant canal, and had a Fontan that was then complicated by protein-losing enteropathy and plastic bronchitis. He had received heart transplantation 2 years and 8 months prior to this presentation with a negative crossmatch. He was seen at a routine clinic visit where his tacrolimus trough was low at 2.2, and he had an elevated cell-free DNA level, and this was his first value that was checked at 4.9%. His echo was stable from his baseline, and based on these results, his tacro dose was increased. He was given a 3-day burst of steroids and was followed up in the following week for labs. His tacrolimus trough then was elevated, and his cell-free DNA was higher at 5.8%. His donor-specific antibodies that were obtained the week prior resulted as negative, and so we admitted him for cardiac catheterization and biopsy. You can see here his hemodynamics from that cath, which were reassuring. And now I'm going to pass along to Dr. Arva to discuss histopathology.
So the biopsy consisted of 4 pieces of endomyocardial tissue, so it was adequate. One piece showed a Coulty lesion, this inflammatory infiltrate in the endocardium. But if we focus on this first piece, we notice an interstitial inflammatory infiltrate here that is associated with myocyte damage. On a different level, if we look at a different piece, we also notice another focus of interstitial inflammatory infiltrate, again associated with myocyte damage. This particular myocyte, here it appears that it has paler cytoplasm. So because we have 2 foci of myocyte damage with 2 foci of inflammatory infiltrate that are really well confined, this was consistent with acute cellular rejection grade 2R3A. The biopsy did not have any evidence of histologic antibody-mediated rejection. The immunostains, this is CD68. And we see here that the stain is positive in the Coulty, so we will ignore this area. But if we look at the other pieces, we just notice some scattered interstitial histiocytes with no significant number of intravascular macrophages. C4D was negative. So the final diagnosis was moderate acute cellular rejection grade 2R3A with no evidence of antibody-mediated rejection and a focus of invasive Coulty.
So based on these results, the patient was given an IV dose of high-dose steroids for 3 days. His regimen was switched to tacrolimus and sirolimus with goals of 6 to 8, and he was discharged home. after which his MMDx results returned and showed an abnormal heart transplant biopsy with antibody rejection and no evidence of cellular rejection, as well as some parenchymal injury. The patient was followed closely and had a repeat cell-free DNA that was rising further to 6.8%, despite having immunosuppression levels that were within his goals. He also had some mild changes on his echo with a decrease in ejection fraction to 52% and a decrease in his strain to -11%. And therefore, he was brought back for a repeat cardiac catheterization, which again had reassuring hemodynamics. And now we will review the histopathology.
So again, we have an adequate biopsy with 5 pieces of endomyocardial tissue. If we look at this particular piece, we notice many vessels that are prominent. So there is evidence of endothelial cell activation. And in this piece as well. Now looking at the immunohistochemical stains, C4D, similar to the prior biopsy, was negative. But CD68 highlights more than 10% of the vessels that contain mononuclear macrophages. So the stain was read as positive. There was no evidence of acute cellular rejection in this biopsy. So the final diagnosis was no evidence of acute cellular rejection, antibody-mediated rejection, which was graded as PAMR2, since we had both histologic and immunologic evidence and no quality effect.
His MMDx returned also continuing to show antibody-mediated rejection without any cellular rejection and mild injury that had improved somewhat with the high-dose steroid burst. So based on these results, we decided to initiate antibody removal therapies. He got plasmapheresis, bortezomib, and rituximab, and initiated a 6-month course of IVIG. We also checked his antibodies to angiotensin II receptor. These were positive, and we initiated losartan, but unfortunately, he was not able to tolerate it due to hypotension and a rise in his creatinine. He did have a normalization of his ejection fraction with these measures, but a persistently abnormal strain measurement. And his cell-free DNA decreased from 6.8% to 3.1% with these treatments. We did obtain a repeat biopsy following AMR treatment, and Dr. Arva is going to go over those results.
So this biopsy did not show any evidence of acute cellular rejection. We do not notice any inflammatory infiltrate in the endomyocardial pieces. If we look closer, we do not see that evidence of vascular activation. The vessels are actually quite difficult to be found in the biopsy. And the stains were negative. This is C4D again. Which is negative. We do not see any vessels that are highlighted by the stain. And CD68. Just highlights some scattered interstitial macrophages, but no intravascular monocytes. So the final diagnosis for this biopsy was no evidence of acute cellular rejection grade 0, no evidence of antibody-mediated rejection, and no quality lesion.
And again, the MMDx agreed with this and showed improvement in antibody rejection features, so no definitive rejection, as well as improvement in injury features. So this first case brought up a few questions for us. First of all, why was there discrepancy between histopathology and MMDx on the first sample? We do see this occasionally in our group of patients. A few different possibilities. One, perhaps there were different samples obtained from the RV myocardium, and these were giving different results. I will note, however, that we have studied discordance rates among our samples when they are obtained as unique samples or when they are split, meaning one piece of tissue is then cut in half and half sent to histopathology and half sent to MMDx. And we find that the incidence of discordance does not differ between the two cases. And so I don't think it's very likely that a large portion of our discordant samples is due to sampling differences. Other possibilities, perhaps there are different findings on histopathology that could induce an abnormal MMDx, for example, quilty lesions. Perhaps there's things that are read differently under MMDx than they are under histopathology, and we need to learn more about what that means. It could also be that there's different time course of changes on the two different tests. So, for example, could it be that MMDx was picking up on changes that are later to be seen on histopathology? Like in this case, MMDx read ABMR prior to then histopathology picking up on some antibody rejection. And then finally, we often ask how we can use cell-free DNA in these cases of discordance. I will note that in this case, with his very elevated cell-free DNA value up to 6.8%, I was concerned about antibody rejection from the beginning. And this is based on some data in adult heart transplant recipients showing that cell-free DNA values in AMR are significantly higher than they are in cellular rejection. And so when I see values of about 6%, I do often wonder if there's a component of antibody rejection. So moving on to the second case, this is a 20-year-old man who had a paramembranous VSD and severe aortic insufficiency and moderate mitral regurgitation, and developed severe LV dilation and dysfunction, pulmonary hypertension, and frequent episodes of ventricular tachycardia. He was listed and transplanted without complications, had a negative cross-match, negative DSA at the time of transplant, and was seen at a routine clinic visit 18 months post-transplant and noted to have a normal ejection fraction but a low strain value of -9%, as well as some abnormal markers of diastolic function on his echo. His tacrotroph at the time was elevated and he was on gold dose Cellcept, and his DSA were negative. But given those echo changes, he was admitted for cardiac catheterization and biopsy. His hemodynamics were notable for elevated filling pressures and a wedge pressure of 15. And we will review his histopathology.
So this is his biopsy. It is somehow limited because we have only 3 pieces of endomyocardial tissue, but each of them had good amount of myocardium. And if we go with higher magnification, we notice that there is a diffuse interstitial inflammatory infiltrate. And in some areas, the lymphocytes seem to attack the myocytes and induce myocyte damage, such as in this area. The cytoplasm of this particular cell became feathery and the nucleus is quite small. And we see more inflammation, which is again diffuse in other pieces. And this piece also, the inflammation is associated with myocyte damage. Again, the lymphocytes are impinging on the cytoplasm of this particular myocyte. So this is a second focus of myocyte damage. Considering the diffuse nature of the inflammatory infiltrate, this was consistent with severe acute cellular rejection, grades 3R, 3B. Given the high grade of acute cellular rejection, we were not able to comment on the histologic evidence of AMR. C4D was negative. CD68 highlighted macrophages, but it was difficult to assess if they are intravascular or in the interstitium. And we can see macrophages with ACR if it's high grade. So basically, we could not comment on the presence of AMR in this case.
So we treated the patient for severe cellular rejection with antithymocyte globulin and high-dose steroids. His DSA were pending at the time of his admission, but we did have the question of whether or not we needed to worry about antibody rejection given his graft dysfunction and non-adherence. And this was a question for us, and we turned to MMDx to help us answer this question.